Hi, friends. Welcome to yet another episode of Innovation in Hematology, a series which has been able to provide the authenticated and real time great speakers lined up for you where we can discuss in 30-35 minutes the latest data and collaborate and contribute to the existing science, the way we do things. It has been our pleasure to have Dr. Nehar Desai today. We'll be talking about PTCY. Nikhil has compiled our own data in a short time, glimpses of what we do at Fortis and the ideologies which we have discussed as a group. It will be great to listen to Nikhil and Nehar Desai in understanding the way what we do and way we do. Because with the limited finances and the mindset and the socioeconomic condition of each transplant center is pretty different. And what practices has been evolved over past 1 decade is the culmination of what we see today. So I think it's a great opportunity for all of us to learn that from the Western world and from India, one of the largest centers for doing the bone marrow transplant. It's my pleasure to hand over to Dr. Nikhil to introduce our speaker and discuss how and which way the PTSI fits in, as we have all been doing in haplotransplants. But is it the way for a mud? Is it the way for sibling transplants? With the ever evolving dimensions of science, we have the pleasure of having a great speaker with us. And as we all know, genomics has been a stronghold at Fortis and Agilis, with 3-day genomics continues to spearhead the entire AML spectrum. And now, Dr. Srinidhi
हाँ
has
तो मैं
been able
हूँ
to establish.
किसने इसको बोला चल जा जा इधर से चल निकल इधर
If
से
you
चल
could,
जा इधर से कौन बोला
I
और
request
क्यों
you.
बोला किसकी जगह है वो
I request if everyone could mute.
किसी
Perfect.
Yeah.
So yesterday only we have launched our new clone detect and clone track in comparison to clone seek. So it will be great to watch out that space from Dr. Srinidhi and Dr. Nikhil, spearheading our myeloma genomic landscape. Over to Dr. Nikhil.
Thank you, Dr. Bhargav. When we were thinking of having a webinar on post-transplant cyclophosphamide, we felt, unlike many other drugs which are approved and which are quite expensive and unaffordable, PTCY actually provides us with a very unique opportunity. It is one of those medications which is easily available. And from our haplotransplant experience, most of the transplant centers in India are very comfortable using cyclophosphamide at high doses. And it doesn't add on to the cost. So I think almost uniformly for haploidentical transplants, PTCY-based GVHD prophylaxis has been the standard of care. But of late, a lot of publications from Princess Margaret and Dr. Nihar has been spearheading many of them, have looked at PTCY in other settings. Can we use it for matched sibling donor, matched unrelated donors? How does it compare with our normal CNI with methotrexate prophylaxis in terms of delays in engraftment, infection risk, and most importantly, overall GVHD prevention when it comes to acute and chronic GVHD? So today we have this very, very interesting talk, and probably it is pertinent for all transplant physicians across India and across the world. Can PTCY be India's answer to affordable, safe transplants? Definitely cutting cost and going with the recent data, having very, very good GVHD prevention without really cutting corners. So before we go ahead, this has been our practice at Fortis Memorial Research Institute. Over the last decade, our protocol, we have been using ATG uniformly for all patients, except the haploidentical transplant. So for myeloid neoplasms, it has been a trio-based protocol, flu trio ATG, ATG at 2.5 milligram per kg for a matched sibling, and 4.5 milligram per kg for a matched unrelated donor, with a standard CNI methotrexate GVHD prophylaxis. Haploidentical transplants, we have been using TBI at 2 grays, along with a PTCY CNI MMF backbone for GVHD prophylaxis. Our ALL transplants have been TBI based. 8 gray versus 12 gray, probably a year or two back, we were always using 12 gray, but now because of recent data and probably lesser toxicity, we have switched to 8 gray, however, retaining the 4.5 gray cranial boost. Side TBI for young fit patients and probably fludarabine if they are slightly older and unfit. Haploidentical transplant, again, flu TBI with a PTCY based backbone. For aplastic anemia, the protocol has remained standard more or less, flu-cy ATG, and we have been doing quite a lot of haploidentical transplants for aplastics, especially high-risk patients who really cannot wait for a mud search. And this protocol has served us well in the last year and a half. ATG flu-cy TBI, 4-grade TBI, again with a PTCI-based prophylaxis. Lymphoma transplants relatively lesser in number, but flu-mel backbone with 2.5 mg per kg ATG for match sibling and 4.5 mg per kg for match unrelated donor, and a 4-grade TBI with flu-mel for haploidentical transplants. With the current GVHD prophylaxis, including ATG, our 100-day acute GVHD rates have been in single digit. It has been less than 10%. Yes, we have had problems with slightly late relapses, but can we attribute that to ATG? Can we do better with PTCY is something which we really would like to hear from Dr. Nihar. So it is my privilege to introduce the speaker for the day, Dr. Nihar Desai. We are all familiar with him. He is an allogenic transplant physician at the prestigious Princess Margaret Cancer Center, Toronto. He completed his internal medicine residency at Lokmanya Tilak Municipal Medical College, Mumbai, followed by hematology and stem cell transplantation residency at SGPGI, Lucknow. Currently, he's pursuing a master's degree at the University of Toronto, Canada. His research, as we all know, focuses on optimizing GVHD prophylaxis while minimizing post-transplant infectious complications and focusing on how we can improve the long-term transplant outcomes. He has authored several peer-reviewed publications in international journals of repute like Blood Advances, British Journal of Hematology, Transplant and Cellular Therapy Journal, and the European Journal of Hematology. He has been a recipient of multiple abstract achievement awards at ASH and EHA meetings, and his research includes transplantation in patients with myelofibrosis, again, a very difficult group of patients to take up for transplant. How can we optimize PTCY dosage for maximum efficacy while minimizing toxicity and infectious complications, and thereby improving the long-term outcomes of allogenic stem cell transplant? Before I hand over the session to Dr. Nihar, I would like to introduce our speaker for next month. Again, something related to allogenic transplant, where Dr. Amin Alausi from MD Anderson Cancer Center, Houston, Texas, would be speaking to us on optimal management of steroid refractory chronic GVHD in today's era. This will be on the 22nd of next month, 7 p.m. to 8:30 p.m. And I would like to invite all who have joined today to register for this webinar as well. This is our team at Fortis Institute of Blood Disorders, where we have 5 adult hemato-oncologists, 5 pediatric hemato-oncologists, along with a comprehensive team of infectious disease physician, molecular hematologists, critical care hematologists, geneticists, and a whole support staff of trained BMT, nursing coordinators, nutritionists, among others. Thanks to this team, we are able to perform transplants for a wide variety of indications, 200 to 250 plus bone marrow transplants every year, thanks to this wonderful team. So I'll stop here. I'll hand over the session to Dr. Nihar. A lot of questions have poured in prior to webinar, a topic which is pertinent for all of us. And hopefully we'll be able to discuss most of them in the question and answer session that follows. Thank you, Dr. Nihar, for joining us, and I'll hand over the session to you.
Hello, everyone. Very good evening. I'd just like to confirm if my slide is in presenter mode and if the slide as well as I am visible on screen, stuff we struggle with on Zoom sometimes. So Nikhil, if you could please confirm.
So the slide is in presenter mode, visible in full screen. Perfect.
And you do see me as well.
No, we're not able to see you.
I don't know how to fix that. Just give me 1 second because I have put my camera on.
I can see you, Dr. Nihar. I can see you, Nikhil. He's visible, Nikhil.
Okay, perfect.
Okay, great. It's better to be visible if there is any interaction. I mean, okay, wonderful. If it's all sorted, then we can start. Thank you again for the kind invitation. I'm really delighted to talk about something which I truly am passionate about. So I changed a bit of the topic to the landscape of GVHD prophylaxis in 2025 because didn't want to restrict myself to just PTCY, although I will be stressing upon PTCY, and I have close to 60 minutes to convince everyone that the way to go forward in 2025 and beyond is PTCY. There are other questions that we need to answer, but PTCY is here to stay. So, as Nikhil kindly introduced, I am Nihar Desai. I work at the transplant center at the Princess Margaret Hospital in Canada, and I have no relevant disclosures pertinent to this slide deck. So, briefly, the objectives of today's talk are to review the transformative impact of PTCY in different donor settings. I'll discuss the optimal combination strategy of with PTCY. Then a little bit of a practical approach on how we administer PTCY on the unit, a little bit of on the unit kind of say. Then problems with PTCY, are there really any problems? I'm pretty sure there are, and then I'll give you some tips and tricks of how we have started navigating this, and then the way forward in 2025 where we all need to collaborate and come up with more real world data for PTCY and even other GVHD prophylaxis strategies if anything comes close to matching PTCY's ability. So this is something which I always use in all of my slide decks. This makes me believe in what we do and tells me that there is always hope. So in 1955, transplantation was something which was unthinkable. There were isolated case reports, and an entire career was commenced based on that isolated case report. Truly, Dr. Donald Thomas wanted something for patients who had no other options, and we've seen transplant grow over the years from just syngenic transplants in the past to then transplanting patients for immunodeficiencies, and then identifying what GVL is, what graft versus host disease is. Initially, we only relied on myeloablation as a means of controlling the disease, so it was just the chemotherapy, but we knew that there was a ceiling effect with that drug. So recognizing GVL was really, really important. And then now in 2025, we've come so far. We know that there is a lot more to transplant than just the conditioning regimen. And we can play around a lot with modulating the immunosuppression post transplant as well. So there is a lot of hope and a lot of area for research after 2025 and beyond as well. The critical barrier to transplant in the past, and even to a certain extent today, I would say, is graft versus host disease. Basically, for someone who's not familiar with this, it is the donor cells attacking the host. Basically, it's as simple as that. There are different cells which attack it. We are not going to get into the immunology of GVHD today. That's not the goal of this talk. But GVHD has remained consistent at close to 20 to 25% over the years. And this is for all grades of GVHD and usually applies to sibling donors, unrelated donors, and all settings together. So this is just a 20,000-foot overview of graft versus host disease. And compared to other diseases, we know that relapse, GVHD, these are the common barriers to successful transplantation. 20% is the golden number that I was talking about. The goal is to reduce it further. When we look at this publication from Hematologica in 2022, it's quite reassuring. Look at the line in yellow. So that's the most recent era. And by most recent, I say it's still, 2011 to 2015. So that's 10 years ago. And we see that compared to the early 90s, the curves have come down. And by that, I mean that GVHD has significantly reduced over the years. Sorry, can I request everyone to please mute their mics? So when we look at graft versus host disease over the years, it has significantly reduced, like I was saying. But in 2008, this was the epoch-defining publication, in my opinion. And anyone who's a transplant physician has definitely read this paper by Professor Luznik and Professor Fuchs. So this is HLA haploidentical transplants becoming a reality with the use of non-myeloablative conditioning for hematological malignancies using bone marrow grafts. So I use a lot of words here which might actually not make sense. So we're talking about high-risk malignancies, but then we are using non-myeloablative conditioning and bone marrow grafts, both of which we know have reduced graft versus leukemia effect. But initially, I can understand the concerns they had, right? GVHD in the haploidentical settings was just prohibitive of transplantation. So they used it in this setting and look at what they achieved. So the donor pool was significantly enlarged, it was expanding all the time, and now haploidentical transplants were a reality. So if you look at the haploidentical protocol, this is basically the original Baltimore protocol and then also the Seattle protocol, which used cyclophosphamide only on day 3. We see that the chronic GVHD, which is the extensive chronic GVHD, and acute GVHD grades 3 and 4 are really, really manageable, even with using haploidentical donors. So this was something which was truly transformative. And understandably, the use of post-transplant cyclophosphamide has increased over the years. Uh, Dr. Nikhil, I still feel that a lot of can we mute the mics, please? Can you hear me? Hello, can you hear me?
Yeah, we can hear you.
Yeah. There's a lot of background noise. I'm unable to. Can I just mute the mic, please?
नॉर्मल था वो उसमें एक बार असिस्ट मिला था फिर वो मेडिकेशन से नाम नहीं ठीक करना क्या नाम है मिस सोनाली दास क्या करते हैं आप
Nikhil, can I please request everyone to just mute the mics? I'm unable to hear myself. Hello? Yeah, so I'll just try and go on. So over the years, the use of post-transplant cyclophosphamide, as we can see here from this publication, has been increasing. So 506% increase in the use of haploidentical donors between 2010 and 2019. So in this last decade, there has been a significant increase, and we're not using PTCY only for the haploidentical donors anymore. At our center, PTCY has been the standard for all donor types, be it sibling donors, unrelated donors, haploidentical donors, or the mismatch unrelated donors. So I'll share some data about using PTCY beyond the haploidentical setting. But this was the first phase 3 data which made us believe that there is scope for PTCY even in the matched unrelated donor setting. And so this is the landmark publication by Bolanos Mead et al. This was in New England Journal 2023, where they compared the regimen of TAC MTX, which is the standard of care for sibling donors, unrelated donors at the time, and they put it to the test against PTCY, tacrolimus, and MMF. So a very well randomized study looking at 214 and 217 patients in each arm, and clearly the winner was PTCY, as we can see here. For all the major endpoints, including the very important endpoint of GRFS, that is GVHD-free, relapse-free survival, grades 3 to 4 acute GVHD and chronic GVHD, the PTCY-based prophylaxis emerged superior and led to improvements in all of these important endpoints. But using this data, can we justify using PTCY for all? Important caveats in this study were that all patients received reduced intensity conditioning. None of them were MAC, and the majority of the RIC conditioning was fludarabine with melphalan. Most patients had received 8 out of 8 unrelated donor grafts. Remember, this is a CIBMTR dataset, and only 28% received related donor grafts. So people had skepticism about using this data and extrapolating it to the matched sibling donor setting. So can we really justify it in the sibling era? We thought, let's look at our own internal data. And for context, at Princess Margaret, they adopted the PTCY based protocol for all donor types in 2015. So we have almost 10 years of experience using PTCY for all donor types. And this was a retrospective study which I was the author on. And we looked at PTCY for matched sibling donor transplants, just restricted to sibling transplants over these years. And we divided this data set into 4 GVHD prophylaxis groups. And the reason for this was that there was evolution in practice over the years. Initially, the legacy group was always cyclosporin plus methotrexate, which is what most centers are currently using as well. Then the investigators at Princess Margaret felt that it would be appropriate to combine ATG with it because there were some problems with chronic graft versus host disease. So that is group number 2. And then when we adopted PTCY, we combined ATG and PTCY. So that's group number 3. And then the fourth group is currently what we are using as standard of care, which is a PTCY based prophylaxis with cyclosporin and MMF, which is what we are using also for unrelated donors and haploidenticals as well. So when we look at these 4 GVHD prophylaxis regimens, anything that contained PTCY emerged superior to anything that did not contain PTCY. That is take home message number 1 from this paper. And this was a pretty homogeneous group of patients, all hematological malignancies only. Every patient received peripheral blood stem cell transplants, and we had a good representation of MAC as well as the RIC conditioning regimens. So if we look at even phase 3 data that was there in the past, it was all PTCY, but after non-myeloablative or reduced intensity conditioning, but nothing existed with myeloablative conditioning. So this was the first real world evidence that we believe we could provide for PTCY after any conditioning intensity. And what we saw was very impressive and similar to what was seen in the phase 3 trial. So it was a real world corroboration of that data wherein anything with PTCY led to close to 50% GRFS. So that is something which is truly promising. But then one may argue that if you add ATG, you get the same stuff, right? So you're getting around a 50% GRFS even with this. So what we can safely rule out is that CNI MTX can be safely put to bed. We are not going to be advocating for that anymore in 2025. So anything which is close to 50% GRFS seems to be reasonable. But the problem with the ATG arm that we noted in our study, and we did a subgroup analysis as well, we saw that there was a significant increase in the risk of viral reactivations, which we didn't encounter to that extent with the PTCY group. So the ATG CNI MTX versus PTCY group, similar GRFS, but at what cost? It does increase the risk of infections and other complications. We didn't see an increase in the risk of relapse, at least in our data set. So this is what we reported a couple of months ago in Blood Advances. And this is what is currently under review. We're reporting a subgroup and of patients who received myeloablation. And again, similar GRFS. So even with myeloablative conditioning, very promising GVHD-free, relapse-free survival. And when you compare it to CNI MTX, it's absolutely no match. So I think CNI MTX, we can safely say that should not be used in isolation, even for the sibling donor transplants. This is something in 2025 we should not be taking for as a standard of care. Again, this was just a retrospective study, one may argue. So now I'm going to give you some prospective phase 3 randomized data as well to support my claim. So when we look at this study, thanks to the Australasian group, and this was also presented at EHA and simultaneously published this year in New England Journal of Medicine, a very interesting control group, a very interesting experimental group, just a true drug regimen, PTCY plus cyclosporin, put to the test against standard of care CSA MTX. Small number of patients, but still, that was what the authors could do. Landslide victory again for the PTCY group. And the metric that matters, which is the GRFS, was again significantly improved with PTCY compared to CNI MTX. So again, very similar results to what we already reported in the real world study. A hazard ratio in favor of the experimental prophylaxis. So again, PTCY with cyclosporin did improve GRFS by reducing the rates of grade 3 to 4 GVHD as well as moderate to severe chronic GVHD. So both these very important endpoints were meaningfully reduced. And as Nikhil was saying, the single digits of GVHD with his ATG group, we are seeing the same with the PTCY as well. So it's just about choosing the right agent. And we can now safely, as I was saying, not use CNI MTX anymore based on all of this data. I just compiled this table of the three phase 3 trials or phase 2, phase 3 trials which have looked at PTCY compared to the other settings, only in the haploidentical setting, basically. So excluding the haploidenticals, when we look at HLA match settings, these are the three trials head to head. We can't compare across trials, but look at the similar number of GRFS, 53%, 45%, 49%, and our real world study also showed close to 48, 50%. So overall, this is the GRFS that we are looking at in 2025, and grades 3 to 4 GVHT in all of these experimental groups are less than 10%. So single digit acute GVHT grade 3 to 4 and 20 to 25% of moderate to severe chronic GVHD, which is very, very promising. So this is what I believe is the true way forward using PTCY across donor types. We do have data to back our claims, and this is what we should be doing in 2025. So again, coming back to this is the golden figure of 50% that I was talking about, and this is what we should be aiming for. What makes this NEJM trial special, and that is what they call the CAST trial? It was the first randomized data using PTCY after myeloablation. So our study was a retrospective study which looked at MAC and RIC, but this is randomized trial and shows similar data, similar results. And also the first randomized data in only sibling donor transplants. If you see the CTN 1703, that is the Bolanos Mead paper, they had just 25% patients approximately with sibling donor grafts. This was exclusively sibling donors, and now we have phase 3 data in all three settings, that is haplo, mud, as well as the sibling donor setting. But do we really need MMF? Because if you look closely, the experimental prophylaxis group for this sibling donor transplants was only PTCY with cyclosporin. So what about the MMF, which is what we are using more often than not? So it's about exploring what the ideal combination is in the sibling setting. We know that PTCY is great. Can it be combined with CNI alone? Sirolimus maybe, if you want a CNI-free approach, or is still the CNI plus MMF the go-to? So I'll just go into a bit of a detail about this. This was published by Ruggeri, retrospective data looking at PTCY alone or in combination with one or two drugs. Many a times we say that more is not always better, but in this case, it was actually better. GRFS was close to the 50% that we are looking for, whereas it was just half of that with PTCY alone or PTCY with one single drug. So probably this was the study which was, driving everything forward. This is stuff that we are comfortable using, and nobody would really want to drop any drugs when it comes to sensitive things like GVHD. So what really is MMF? This is how mycophenolate looks chemically, and this lower down is its active moiety, which is the mycophenolic acid. And if we go back to med school days, we do know that lymphocytes require de novo purine synthesis for DNA synthesis. And what mycophenolate does is that it blocks a very important enzyme, that is inosine monophosphate dehydrogenase. By blocking this, you reduce the proliferation of lymphocytes, and therefore it acts in autoimmune diseases, it acts in graft versus host disease. Wherever the lymphocytes are the central player, mycophenolate is known to work. Another thing that makes mycophenolate special is that it is a more selective inhibitor of type 2 IMDPH, which is more exclusively expressed in lymphocytes. So that's something that works in our favor. And this is basically how MMF works. And in a dog model or a canine model, Professor Staub's group from Seattle showed that the combination was better, and that is how it has been used in the clinics. That is why this combination was first conceived. Either agent alone did not do as well as when they were given in combination. But does this really apply to PTCY? This was just in isolation. With PTCY, things can be different, and I'll talk about this in the next slide. So mycophenolate leads to some intestinal dysbiosis, and we are well aware of that, and also the diarrhea that sometimes accompanies mycophenolate. So this was a study which looked at the short chain fatty acids in fecal samples in mice. So we can see here in the yellow bars that acetate, propionate, and butyrate, all of these important short chain fatty acids, are significantly lower in the MMF group compared to the control group. So there is some intestinal dysbiosis that occurs with using mycophenolate. And we know that in the important role of gut microbiota in 2025, I don't need to tell the audience that today. And definitely, when there is disturbance of this gut microbiota, it can translate into something which we don't like. Also, in addition to just being immunosuppressive, mycophenolate also has a lot of antibacterial effects. It causes a shift in the microbiome towards these organisms here in yellow, which is the Staphylococcales, the negative acutes. So basically, there is a disruption of the gut microbiota, and these organisms produce what we call GUS, or that is a beta glucuronidase. So these beta glucuronidase and organisms are increased. And what beta glucuronidase does is causes MMF to be converted to its active form, which is the mycophenolic acid. Eventually, we have more active MMF, therefore more mucosal damage. And we know that wherever there is mucosal damage, there is a likelihood that GVHD will be increased at this space. So this is well known. This is what Rotesh Mehta showed in 2022, that there is a shift in the microbiome, and that leads to mucosal damage because of increased MPA, therefore increased GVHD, which is paradoxical to what we expect. But this is what the data showed. When they compared PTCY TAC MMF with just PTCY and tacrolimus, there was a paradoxical increase in graft versus host disease. So more immunosuppression here led to more GVHD, which is very surprising. But the proposed mechanism was what I showed in the previous slide, that the intestinal dysbiosis could have contributed to this. This is what they postulated. And again, this is just hypothesis generating data. There is not much of solid lab evidence behind this, but it certainly makes a case for considering dropping the mycophenolate. Um, Again, surprising results yet again, reduce the risk of relapse. So when we increase immunosuppression, we expect an increased risk of relapse. But here they said that, well, with the triple agent regimen, there was a reduction in the risk of relapse. So the data is all over the place, and we can't really tell if we should be increasing MMF or not, or using it at all or not. So this is basically how PTCY works at a molecular level, or at a cellular level rather, sorry. It leads to a preferential recovery of Tregs. So these are the good T cells that we want. We want to destroy the alloreactive T cells, lead to a recovery of the T regulatory cells, so as to get a good balance of GVL and GVHD. And if someone's not read this paper, again, a very highly recommended paper from Professor Kanakri's lab. And when you look at this PTCY 25 and PTCY 100 arm, we can see that the FOXP3 expressing regulatory cells are increased on day 21. And MMF reduces Tregs. So is it really counterproductive? There is a possibility that it may be counterproductive. We want these Tregs to be preserved, and MMF may lead to destruction of these Tregs by just not having this preferential proliferation. So it might be counterproductive. This is something we need to think about when we are moving forward. But again, enough about MMF and enough about sibling donors. Maybe we continue to use it. It's not the end of the world, but we need to explore more even in the mud setting. We know that PTCY is good, but the combination tested is CNI plus MMF. There's limited data about using ATG, PTCY plus CNI, and also there is upcoming data about bendamustine, most of which is also from India and some from Russia as well. So I'll be talking a bit about that. At Princess Margaret, we have seen magic in the mud setting with this low dose ATG and PTCY combination. Again, this manuscript will be out in print soon. What Nikhil was pointing to, low dose ATG with PTCY, single digits acute GVHD, that's acceptable, that's great. But look at the moderate to severe chronic GVHD. For the first time, we have seen less than 20% moderate severe chronic GVHD at 2 years. And that is the more promising part that I'm talking about. Acute GVHD, yes, we have seen that less than 10% is easy to achieve. Even with ATG, it's possible. But it's probably the moderate to severe chronic GVHD, even in mud setting, which is for the first time less than 20%. So these numbers were very reassuring to us. And obviously that translated into good GRFS as well. And when we talk about ATG and PTCY, immediately we get asked about what was the infections. Here we are. So this is a pre-Letermovir data set, and we see that a 20% rate of CMV reactivation. Again, I do acknowledge that a lot of our patients are CMV negative. So this is very much unlike what we would expect in India, where most recipients and donors are positive. And also when it comes to EBV reactivation, which is clinically meaningful, our rates are close to 20%. So 20% rates of both. And when we looked at the post-Letermovir data set, the rates of CMV have further gone down to less than 10%. So this is something that's very reassuring. And we do have the privilege of, having patients with negative serostatus. So that's something that has to be interpreted with caution in the Indian context. How about bendamustine now? There was this question which was brought up to me by Nikhil. So I looked up the data. There isn't a lot, to be very honest. But there is this one study by Professor Nayar's group from India. One patient received MUD, so it's predominantly a haplo and a sibling donor data set with quite a few unbalanced baseline characteristics. Surprisingly, a lot of patients received myeloablation with PTCY, and as we know, myeloablation increases the risk of GVHD. So that is what was seen with the PTCY group. So that might just be a false alarm. We really need to have a good baseline balance between the groups. It was a heterogeneous diagnosis. There were non-malignant as well as malignant indications. It included adults plus pediatric patients, limited number of patients, I think close to 50 patients, and a short median follow-up duration. So again, bendamustine may be a possible option, but we really don't have the data to back it. And if we look closely, yes, there was a thumbs up kind of a sign with earlier engraftment, but look at the chronic GVHD here, right? I know it's not clinically significant, but certainly with more follow-up and more numbers, this was definitely trend towards significance. So something we really need to watch out for with data which is limited by number and the median duration. So before we take the big jump, I'm really mindful about this bendamustine data. What about abatacept, another drug which is, actually the only drug which is FDA approved for GVHD. So PTCY really doesn't need to be approved. It's a $50 drug, but abatacept was approved recently. It's a recombinant fusion protein, and what it does is that it blocks the co-stimulatory molecule. So for a T cell to be activated, it needs two keys. Basically, it's like a lock which has two keys. The first key is the antigen presenting cell and the T cell receptor interaction, and then is the co-stimulation. So this is where abatacept comes in, and it blocks the AT86 and the CTLA4 interaction and leads to the T cells not being activated, and therefore they undergo apoptosis. So this is the mechanism of action of this drug. And there was a recent publication in Blood Advances from the San Diego group using a CNI-free regimen. Again, these are the buzzwords in 2025, right? We don't like CNI. So CNI-free regimen, extended course of abatacept was used. So beyond the 5, 14, and 21 that we are more used to seeing, this was also given at monthly intervals between 1 month and 6 months. So 5 additional doses, and no patient received ATG, which is surprising because 68% of the patients received myeloablative, unrelated donors. So it's really not the standard of care anymore. So this is my critique of this data set, but it is what it is. And the GRFS was so much better with the abatacept and PTCY combination. I would have loved to have a data with PTCY abatacept versus PTCY CNI, and I'm sure that someone is thinking of doing this trial, and that would really answer more questions than this data set really did. But the most important question that I ask in this data is that is TAC MTX the standard of care anymore, especially if you're using MUD donors. I don't think anyone is using only TAC MTX. Most people would be combining it with ATG, and that is my biggest critique of this study or trial. But it did show that CNI-free regimens are possible. So this is how we do things at Princess Margaret, and I'll be talking a little bit now in the next few slides about some practical aspects of things. So our standard reduced intensity conditioning regimen is fludarabine with 2 days of busulfan and 2 gray of TBI administered on day -1. Most of our patients get GCSF mobilized peripheral blood stem cells. And if we are using myeloablation, we don't use the TBI and instead use busulfan for 4 days. Uh, for MUD donors, we used ATG in combination with PTCY and cyclosporin. So the dose of ATG we use is 2 milligrams per kilogram, as I've shown in the schematic here. And the PTCY dose we use is 50 milligram per kg per day, which is the standard. And now we've started a pilot study, which we presented at ASH and also at ASCO, where we reduced the dose to 35 milligram per kilogram per day of PTCY in the mud setting with promising results. I'm also going to show some of those results in the next couple of slides. So this is basically the schematic of the way we do things here. And the hydration protocol, again, to get into more details about PTCY administration, we use PTCY at either 50 or 35 milligram per kg doses. And we start the hydration at 75 milligram per meter square per hour, a couple of hours, basically 4 hours before we give the first PTCY, and continue it for 24 hours after the second dose of PTCY is administered. We administer PTCY as an infusion over 1 to 2 hours, depending on the patient's underlying condition, but usually we get away with 1 to 2 hours. And our dosing schedule for MESNA is the equivalent dose for PTCY. So that's 100% dose equivalency. And we give it in 4 divided doses between 12 and 15 milligram per kilogram. And that is administered as you can see here in the second schema. We start the first dose at half an hour before the first PTCY, and then dose it at 2, 4, and 12 hours, and similarly on day +4 as well. So that's half an hour before the first dose, and then 2, 4, and 12 hours. So this is how we do things on the unit here. But not all weight is created equal. We know that we do see a lot of patients on extreme ends of the weight spectrum. So there are 3 ways in which we typically look at weight, right? Total body weight is what the real weight is. You stand on a scale and this is what the scale shows. So what's the problem with using total body weight? If you have someone who's 150 kilos, I'm really not sure I want to use 150 into 50 milligram per kilogram, right? So that's the problem of maybe overdosing these individuals who tend to have more fat mass than muscle mass. So that's when the concept of ideal body weight comes in. And this is basically 50 kilograms as the standard or constant, plus we add 2.3 kilogram for every inch that you are above 5 feet, and the standard gets reduced to 45.5 if you're a woman. So basically, this is the ideal body weight of an individual. There is a problem with underdosing with this because some people may be short, but they may be more muscular and process drugs differently. So that's where the concept of an adjusted body weight comes in. And that's basically a compromise between the first two that I spoke about. And the adjusted body weight is whatever adjustment factor you use into the difference between the two weights, that is the total minus ideal body weight. So the commonly used adjustment factor is either 0.25 or zero point 0.5, and this is what we use when we encounter an obese individual. So adjusted body weight is what we use, and this is what our pharmacists on the unit recommend. And there is also data to back our claims. So this was from the MD Anderson group by the pharmacists who led this study. When we are using high doses of post-transplant cyclophosphamide, ideal body weight is what they recommend, and the alternate that they recommend is also probably using an adjusted body weight, but using the 0.5 or the 50% adjustment formula. So it's up to interpretation because there is very little data to say what you should do for someone who has a BMI more than 35. So for someone between 30 and 35, you can use either of the two. Anything more than 35, it is dealer's choice. You can use what you like. There will always be problems with overdosing or underdosing. So this is something to be mindful for. And the Italians do it in a little bit different manner. And this is from Professor Bacigalupo's group. Conditioning regimen could be anything. They also use RIC and MAC, but they uniformly use bone marrow graft. So a lot of bone marrow harvests at their center, I'm sure. And they use cyclophosphamide differently. And they use it on days +3 and +5 instead of 3 and 4. And the reason Professor Bacigalupo has mentioned this multiple times at his talks is because he feels that with myeloablation, giving more chemo on day 3 and 4 together, he saw that there was a lot more mucositis with this approach. So he tried using 3 and 5 and they had good preliminary results. So they continued using the same. There is some data in mice models which says that it is equivalent, but in humans, it's not been compared head to head. So most centers would be using 3 and 4, but this is the Genova protocol which uses 3 and 5. So again, there is no right or wrong when it comes to cyclophosphamide. Is it better than 3 and 4? We really don't know because, as I was saying, no head-to-head data. But if you look at the age more than 60 subgroup here, 30% non-relapse mortality, I think that's a little bit too much. But it could be because they are receiving myeloablation and uniformly receiving bone marrow grafts. So this is something that might lead to delayed engraftment, more mucositis, more GVHD. I don't know what was leading to the NRM, but the 30% NRM is a bit concerning when I look at this data set. But again, we've spoken so many good things about GVHD in the short term, but its protective roles go beyond graft versus host disease. And this is stuff which we just published. It got online yesterday. The impact of GVHD on, the impact of these different prophylaxis on second primary malignancies. Over the years, we had in this data set close to 20 years of follow-up for the first patient, and the median follow-up was more than 7,000 person years. So very long and comprehensive data set. We saw that with PTCY, we saw a reduction in the second primary malignancies. And the reason behind this, what we hypothesize, is that when you reduce chronic GVHD, you do reduce the rates of second primary malignancies. Because if you look at any data from the past, it is mostly squamous cell carcinomas of the esophagus and squamous cell carcinoma of the oral cavity, the buccal mucosa, the tongue carcinomas. And most of these are secondary to graft versus host disease in those sites. So if you reduce GVHD, there is a potential that in the long term, you're actually reducing the risk of second malignancies as well. So this is something that we recently published, and we are continuing to follow patients, delving into more details about the sites of organs which are affected by these second malignancies. But this is promising. And the less GVHD, as I was saying, translates into less second primary malignancies. This is, again, just a snapshot from the paper, which is now available online. But we do need to acknowledge the problems that we see with PTCY. It's not always just the positives, right? In medicine, it's never just positives. We have to balance it with the negatives. So what are these real world issues that we see with PTCY? And as Nikhil rightly pointed out to some of those, it's the delayed engraftment, viral reactivations, hemorrhagic cystitis, cardiac toxicity, fluid overload, and bloodstream infection. So all of these are real concerns, more so in countries with limited resources. So I'll be talking about the data which shows that these issues exist, and then some mitigation strategies. Risk and reward has to be benefited, that like I was saying. So when we look at the CMV reactivation, this is CIBMTR data. So again, we know that it's large data set, more than 2,000 patients here. Any donor type, we use the PTCY, there is an increased risk of CMV reactivation. This is what Goldsmith showed. And very important to be mindful of this data in 2025. Well, it's great quality data, but it's from a pre-Letermovir era. So yes, we don't fear CMV anymore to that extent that we did before we had Letermovir. I don't know if everyone can resonate to this. Some people will not like this statement, but honestly speaking, it has been a real game changer, and I have some data to show that as well. Again, this is a slide which I already showed. PTCY is increasing, so we expect that CMV would increase, and thankfully we have Letermovir now. And this is the phase 3 data by Professor Marty, who unfortunately is not with us anymore after he had an accident and unfortunately passed away. But the data that he provided really is so promising with Letermovir. This is phase 3 data, randomized data across donor types and across high-risk groups. Look at the Letermovir arm. There is so much of a difference compared to the placebo arm. So again, Letermovir works. This is the summary of the phase 2 and the phase 3 data, which led to the approval of these drugs, and clinically significant viremia is reduced in half. So 37% versus 60%, and at both time points, 14 and 24 weeks, with minimal to no side effects is what I would say. I've never really had to discontinue Letermovir for any of my patients in the past 3 years. This is real world data from Stanford across donor types, patients receiving ATG as well. So high risk groups, also mismatch unrelated donor settings. Look at the differences with the Letermovir prophylaxis. This is the orange group. And as we can see with Letermovir prophylaxis, nobody has really got CMV end organ damage or CMV disease. So this is promising data. We also have real world data from the Princess Margaret Hospital. This was led by my colleagues from PMH. Very high risk group, and that's the reason this data is important. because this population uniformly received ATG and PTCY. So even with this combination of immunosuppression, the letermovir group did so much better, and we had similar numbers compared to the phase 3 trial as well. So again, promising results from our center. And we are also expanding its use as secondary prophylaxis. So let's say if someone has a reactivation, you treat the reactivation, you can always reinitiate letermovir if you feel that there is a concern for a subsequent reactivation. So we treated 39 patients this way, and only one patient experienced a second CMV reactivation while being on letermovir. So it is promising to be used as secondary prophylaxis as well. The second concern that we have with the PTCY is this risk of bloodstream infections. And not all bloodstream infections are the same. They are very different in different parts of the world, and that is where the microbiota of the entire hospital, so your antimicro your what do we call it, the microbiologist will provide you with the antibiogram, and that is something which really we have a lot of issues with gram negative bacteremia in India, and bloodstream infections are something that we really need to be mindful of. And the reason we see that is because of the mucosal barrier injury that PTCY causes. It causes a lot of gut mucosal injury, which can lead to transmigration of bacteria and lead to what is now defined as MBI LCBI, that is the mucosal barrier injury associated bacterial infection. So if we look at again the CIB-MTR dataset, they show that anyone who receives cyclophosphamide has a higher risk of getting a bacterial infection, be it for sibling transplants or haploidentical transplants. So this is another side effect that we need to be mindful of. So what's the way forward? We also face this issue, and in July 2024, we decided to initiate a pilot project wherein we reduced the dose of PTCY from 50 milligram per kilogram on 2 days to 35. So that translates into a total dose of 70 milligram per kilogram over 3 and 4. And look at the rates of bloodstream infections. This was presented at the recently concluded ASCO meeting, and we saw that the rates of BSIs were again reduced close to 50%. And thankfully, we see a majority of gram positive infections, and this is where the Indian context might be very different, and therefore we need to generate data. I'm not recommending PTCY for everyone, but probably dose optimization is something that we should be attempting to do if we use PTCY. Because honestly speaking, nobody has tested these doses in a prospective randomized manner. So it's all up for takes. Again, another concern that I was talking about is the fluid overload can be a problem in patients with pre-existing cardiac function, cardiac dysfunction or kidney dysfunction. What we saw in our study is that when you reduce the dose, you reduce the hydration, and therefore you also reduce the risk of fluid overload. And this is the commonly accepted definition that everyone is using. This was provided by Rondon et al. So grades of fluid toxicity, this is what we routinely monitor. And we also initiate monitoring BNPs so that we can better diurese these patients. We do BNPs on every day starting from day +3 up to day +6. So 3, 4, 5, and 6. And our diuresis strategy is based on targeting a BNP and trying to keep it as low as possible or get it back into the normal range if possible. So these are the commonly used grades that we use for publishing our manuscripts and reporting data. So just wanted to summarize what I spoke about. PTCY is definitely here to stay. It's a great drug. It's a very cheap drug. It makes transplants very feasible, but it demonstrates also some issues which I have already acknowledged. We need to find the ideal combination, the ideal partner for PTCY, and that could be different for different donor settings. It could be ATG for the mud setting, it could just be cyclosporin without MMF for the sibling setting, or it could be a combination of all three for haploidentical transplants. Also, the optimal dose of PTCY needs to be explored. Are we going for a lot more dose in the sibling donor setting by giving 100 milligram per kilogram? Is there a way to go it down? Definitely, we need to acknowledge that the global burden of immunosuppression is reduced. And what I mean by that is if you reduce the risk of chronic GVHD, you're definitely reducing the overall time on immunosuppression. And with that comes reduced rates of second malignancies, which I was showing the data for. And this definitely translates into improved outcomes. We have not even spoken about quality of life of patients living with chronic GVHD, but it is quite miserable. And Professor Lee's group from the Fred Hutch has really shown that comprehensively over the years. What we need moving forward is head-to-head trials comparing PTCY with other commonly used drugs, especially in the MUD setting. We can compare ATG versus PTCY. We can compare abatacept versus PTCY. And these are the studies which beyond 2025 one needs to perform. So I'd like to just thank by acknowledging the team at Princess Margaret. And this is a picture that we clicked from a drone at the recent survivorship meet that we have. We have more than 700 long-term survivors who attend these meetings annually. And I'd really thank all of them for this. And I hope that this didn't lead to any lecture algia. I'm very happy to take questions or rather, discuss these things further. Thank you. And back to you, Nikhil.
That was an excellent talk, Dr. Nihar. Thoroughly enjoyed every minute of it. You have actually comprehensively covered the entire GVHD prevention landscape, not only PTCY, it's a bit of ATG and what are the new things and what are the permutations and combinations which can lead to a maximal GVHD prophylaxis while minimizing toxicity and reducing the risk of relapse at the same time. And I think, like you rightly pointed out, GRFS would be a great parameter to monitor. And that would be something which all of us, I think, should look at in our data sets. So to start off the discussion.
Thank you, Nikhil. I really appreciate the invitation again, and I really enjoyed making this slide. So I hope we have a good discussion now.
Absolutely, because this is, I mean, you have covered most of the questions which we have collated, and you have covered the evidence base for them as well. But to start off the discussion, whenever we have used PTCY, especially a couple of patients in a matched sibling donor setting, we have been always worried about the delayed engraftment. So in your practice, what is the median time to neutrophil and platelet engraftment when you use PTCY in a matched sibling donor and a matched unrelated donor setting?
Great question, Nikhil. Sorry, I left out those slides. We did present that at ASCO, and as you rightly said, there is a bit of a delay with PTCY, and there is also CIBMTR data to back this. There is a delay of close to 2 to 3 days with PTCY, be it in any setting, haplo, mud, or in the sibling setting as well. So our median time of engraftment, and mind you, we never use GCSF unless under extraordinary circumstances. So that is something which is slightly different from what the practice is in India. Using GCSF might help, might benefit, but what our group has noticed is that it leads to a delay in platelet engraftment. So that is why we are very mindful of not using GCSF. We do use it sparingly for our myelofibrosis transplants, those with big spleens. But after we've started the splenic irradiation protocol, we've seen significant improvements with time to engraftment there as well. So without using the GCSF, our median is close to, let's say, 14 to 15 days for the neutrophils and closer to 18 days for the platelets, sometimes a bit longer. And this is what I mean for the majority, the bulk of our transplants are AML. So this is for AML. And when I look at myelofibrosis and just bulk up everything together, it would definitely make it 16 to 18 days. And that is where I wanted you to weigh in, because I know that there are these challenges in the Indian setting with gram-negative infections, which may be a major deterrent. So are you guys using GCSF for all types or all donor types, and what days do you start on?
So we use GCSF only for haploidentical transplants routinely. We start from day +5 till engraftment. For matched sibling donor and matched unrelated donors, we try and avoid it as much as possible. If patients have a serious infection, then probably towards the later part of transplant, we use it to slightly have an earlier engraftment. But the only setting where we routinely use GCSF is a haploidentical transplant.
Okay, I have one more point to add. So when we did reduce the PTCY dose from 100 to 70, so which is the pilot project that we are currently doing also as a quality improvement project, because the rates of BSIs were really, really very high. With that, we also noticed that platelet engraftment was a couple of days earlier. Neutrophils were still around 14 to 15, but platelets were engrafting around 17 or maybe 15 or 16 as well. So 1 or 2 days earlier, again, it's a it's a prospective study, but we really are not looking at that as an endpoint, right? So there might be a bias. So I'm not going to make strong claims for it. I will admit that with PTCY, you will expect a delay of 2 to 3 days compared to a non-PTCY approach, and this is what is being observed everywhere.
Absolutely. For our standard flu-trio ATG protocols, at least in a match sibling donor setting, we usually see an early engraftment, maybe between day 10 to day 13. So probably, like you rightly stated,
2 3
an
days.
additional 4 to 5 days or 3 to 4 days is what would come in when we use PTCY.
Yeah.
And you provided very good data from your center as well as other studies regarding the infection rate. So in our center, actually, where we use ATG uniformly for all our patients, our CMV reactivation rates are close to 60%. And this is again before we started using letermovir. Right now, for all our transplants from day 4, day 5, it's been a standard practice to use letermovir. So off late, I think we have been seeing quite a few significantly reduced CMV reactivations. But just to elaborate on that, apart from the CMV and EBV, which we commonly see, how often do you encounter other viral reactivations, and especially something of concern, a BK virus, hemorrhagic cystitis? Do you see that in a matched sibling and matched unrelated donor transplant setting?
Again, very good question. So we really don't, to be honest, Nikhil. We've looked at that data as well. We don't have high number of patients. So even when you look at it in a competing risk model, it comes to very low numbers, like very few events. Uh, we've done close to, I think, more than 150 sibling transplants using PTCY, and we would have seen in less than 10% patients BK virus hemorrhagic cystitis. There is transient hemorrhagic cystitis, which could be just because of the conditioning, the thrombocytopenia. You have very low titers of BK, but not grade 3, grade 4 toxicities, no clots, nothing that requires treatment, just a little bit of hyperhydration and taken care of within a 2 or 3 day period. So, not concerning BK virus hemorrhagic cystitis. So, a lot of these data, what I find is that the way things are reported also has to be interpreted with caution, because many a times you would report global numbers and it would be like, okay, it's quite prohibitive, but are we really treating all of those BKs? Are we treating all of those EBVs as well? You might just get asymptomatic reactivations, but if it doesn't translate into treatment requiring infections, I think that's still acceptable.
Absolutely. In fact, most of the EBV and BK reactivations, we rarely react to it. So
Correct.
I think
That's what I was referring to, because even with the ATG PTCYs, a lot of times we get reviewer comments which are like, okay, so these rates of infection seems really promising, but how? And then we're like, okay, because we're reporting clinically significant infections. If you report every single PCR that's positive, let's say the EBV is just 3,000 copies, we're not going to act on it. So
true.
anything more, that's the reason I reported anything more than 10 log 5 is because that is where it becomes actionable. And by actionable, I don't mean rituximab. I also mean just tapering immunosuppression, which is the first action. So
True.
not a major step. And with this ATG PTCY combination, we are able to taper off the CNI much earlier. So what we have seen as a collateral benefit, I would say, is reduced exposure to the CNI, and that is, I believe, also important because it means lesser monitoring. It means lesser exposure to drugs which lead to kidney injury, hypertension, and patients really don't like using CNI for long because they have to come in once or twice a week for CSA levels. So if we can get away with reduced exposure, probably that helps. And we've consistently shown that this combination is not increasing the risk of relapse. We're actually in the middle of comparing it with the CIBMTR control arm, which is the publicly available data set. And the ATG PTCY combination compared to PTCY CNI MMF for all donor types, it has not translated into improved relapse, reduced relapse or increased relapse, whatever it may be. It's almost the same numbers, and the only thing that's significant on the MVA is just the DRI and the remission status, which is obviously known factors for relapse.
And I mean, that was actually my next question. When you use PTCY with ATG or PTCY alone, how quickly can you taper the cyclosporin? So early taper, would you start by day 60 or probably a little earlier if there is no GVHD?
Yeah, so great question, Nikhil, again. So I definitely gives us more reassurance to start tapering early, and by early you rightly said by day 60, but we don't do a very gentle taper, we do a quick taper. So I also believe that Dr. Holton's group is doing the same. They in fact stop cold turkey. So from I believe from Roswell Park, they've started doing that. They just stop it on a particular day without a tapering schedule. So that's just the cold turkey approach. We're not yet doing that. So we start on 60, and by 75 or at best by day 90, everybody is off CNI in any case, even with PTCY, with ATG, even a bit earlier.
Right. I think we'll take a few questions in the chat box before moving ahead. Dose of letermovir and tacrolimus. Is it like cyclosporin? I don't think there is a dose adjustment with tacrolimus specifically. Is it the same?
No, there is no dose adjustment, right? As you rightly said, with cyclosporin, we drop it to 240 milligrams. With tacrolimus, we continue to use
Continue the
at
full dose.
480. Again, we don't use tacrolimus, so frequently we just use the 240 milligram with the cyclosporin. But if you're using tac at your center, definitely go for 480. There's no adjustment.
And Dr. Ashish has a question. For ALL haplotransplants, any expert comment for TBI-free conditioning?
Um, well, I mean, for ALL, we do know that a TBI-based regimen is better. I mean, there is some data in the past as well. It would be our aim to deliver a TBI-based conditioning if there is a particular indication and you want to myeloablate. We really don't play around a lot with conditioning regimens just for the sake of homogeneity and data, as well as we then know what's really going wrong. Our standard non TBI based myeloablation is fludarabine with 4 days of busulfan. That is what I would then use. If you want to use a reduced toxicity conditioning, you can use FPT 200. It's a very low dose of TBI if that is permissible. If not, then really it's dealer's choice. You could use Flumel as well. So with conditioning regimen, really there's no right or wrong answers, and I feel that I would definitely be tempted to use a TBI based conditioning for ALL. I don't know what your thoughts are, Nikhil.
No, we always go for lymphoid malignancies, especially ALL. We always use TBI-based conditioning. But I think Dr. Ashish's question is very pertinent because many centers don't have access to TBI. So in
Correct.
such settings, when we have to do a transplant, what is the next best option? Is something I think that's what he would
Yeah,
probably.
I get that. Yeah, I probably missed that about the availability of TBI. So I feel that if that's not available and you want to myeloablate, go with Flu-Bu-4. If you want to not myeloablate, maybe just go with Flumel. There's enough experience with Flumel for a lot of centers in India. I believe Flumel, Dr. Mehta is using Flumel for a lot of years, I guess now at Amrita.
Right, right. And you mentioned in your pilot project, you are cutting down the dose, you're coming up to 35 mg per kg. In elderly patients, can you really go down beyond that? Some data regarding, even coming down to 25 mg per kg
Yeah.
for 2 days. So what is probably, in your opinion, the lowest dose of PTCY that would be effective? I know it's a very hypothetical question, but in elderly patients, or you probably where somewhere you would want a earlier engraftment, would you cut down the dose further?
Uh, Again, Nikhil, no right or wrong answer here. I know there is some data which exists even with 25 into 2. Again, it depends on what are you using in combination with that, right? And if you're cutting it down to a significant extent, I would definitely then not be in favor of tapering cyclosporin early. So we'll have to reach a balance of things. I'm really not sure of what is the lowest feasible dose. That is something that needs to be worked out in the lab and then translated into clinical setting. Even the 35 that we came up with, I'll be very honest, it was just an arbitrary figure because who knows what is the right one, right? So we said we'll try with 35. It's not a significant reduction. And we always have the backbone of ATG. So that's why we tried only in the setting where we're using ATG with PTCY. We've still not
हाँ हो
started
गया है
using it for other types
बंद
where we're
करना है क्या
only PTCY.
हाँ हाँ लगा लीजिए
Again, Dr. Ramaswamy Dr. Ramaswamy has a question. Optimal MMF dose, 15 mg per kg per day or 30 mg per kg per day. My understanding was it's 15 mg per kg per dose, probably. So, what is your take on the MMF dose? I think he's referring to a haploidentical transplant with the PTCY platform.
So haploidentical, definitely 15 mg per kg per dose is what you said. and 3 doses basically. So that would be the standard. We're not using 30. Trying to even drop it further in the sibling donor setting and in the mismatch unrelated donor setting in haplo, we'll continue with the 15 milligram per kg per dose schedule that we are currently using. I don't know if anyone's using 30. I think that's a bit too high. And I believe that also is 30 per kg per dose, right?
Per
I
day.
believe.
He is referring to a total dose of 30 mg per kg per day, actually.
And also 15 mg per kg per day.
Per day, yeah.
I would say that then that's a bit too less. It would be 15 mg per kg per dose into three, right? So yeah, I don't believe that. I don't know if anyone's using 30 per dose.
Yeah, but in the quoting, it was mentioned in your slides. If you see that Italian protocol, it is a 15 milligram per kg per day in that protocol. And also,
Right.
you also mentioned in your slides also it was a 30 milligram per kg per day. So it is not the dose based, it is a TID dose, but it was mentioned in Italian, it was 15 milligram per kg per day in the slide. And also 30 milligram per kg per day in your protocol. That's a confusion. That's the reason I asked. Thank you so
Oh,
much.
no worries. Let's just go back to the slide. I might have just, it might be a typo from my end, but this is 15 milligram per kg per day, which is the Italian protocol
Italian
that,
protocol says
yeah,
15 milligram per kg per day, but usually, as you rightly mentioned, it was a 15 milligram per kg per dose. But
right,
usually, most of the people will stick on to the 30 milligram per kg per day in 3 divided dose. 45 is not most of the people are following it, but the 15 milligram per kg per day was per dose will be little on the higher side. That's the reason I asked the question. But even if you see that your slide also it shows 30 milligram per kg per day.
no, we're using 15 per kg per dose
Per
3 times
dose.
a day. Yeah, yeah,
Okay.
yeah.
Okay.
That's the
Thank
one.
you.
I think that might be an error from my end.
Thank you.
And I would like to actually add on to that Ramaswamy sir's question. In a setting where you can compare MMF with abatacept, because we have had our problems with MMF, slightly delayed platelet engraftment, and in a haplo setting that ultimately leads to a higher risk of BK reactivation. So do you think going forward, PTCY would be a better drug? PTCY TAC MMF versus PTCY TAC abatacept. So what is your take on that?
Sorry, my screen's frozen, Nikhil. I couldn't hear you, or
Oh,
can you
yeah.
hear me?
Yeah, we can hear you. So
Okay,
my
great.
question was, in the setting, do you think in a haploidentical transplant, MMF can be completely avoided if we add abatacept instead of MMF? Because very often we have had problems with MMF, delayed platelet engraftment, and when patients have a low platelets with BK reactivation, they end up having hemorrhagic cystitis and all sort of problems.
Agreed.
So, do you think replacing abatacept would be a viable option?
I mean, it can definitely be a potential option. I don't know if there is any data for this, but are we really sure that we are delaying the platelet engraftment because of the MMF, or is it just the PTCY? So we don't know if we'll see the same issues even with the abatacept replacement, right? So that is why I was saying that the abatacept PTCY combination, which San Diego recently reported, they said the rates of GVHD was 0%, but there's a lot of data that they still haven't reported. It's a preprint, it's available, but I'll probably have to do a deeper dive into it. I'm not sure of anything else which has used PTCY abatacept in combination. I'm really not aware of the data. You can fill me in if there's anything.
So again, probably early data with abatacept does show a lot of encouraging results, but yes, I think there are no large data sets or randomized study to back it still.
I agree. So I still think it's something that can be explored further, like PTCY abatacept combination, or maybe just abatacept with CNI MTX. I know that the ABA2 was the trial that led to the approval. But again, if you have something as good as PTCY, I think the way forward would be to rather dose optimize the PTCY. We have a very good agent, very cheap, very easily available. I think the way forward should be to optimize using that drug rather than, keep adding drugs to it. Rather, we get the right balance of that with the ATG or without the ATG with abatacept. That is a second question. But figuring out the right dose of PTCY should probably be the way forward for now, I feel.
Right. Dr. Ranjit has a question. In benign transplant, how strong is the data for PTCY in mud and matched sibling donor? I think you touched upon this during your presentation, but that was
So
mostly on malignant transplants. Yes.
absolutely, absolutely. I restricted that to only malignant transplants. So in sibling donor transplants for let's say aplastic anemia, we are not using PTCY. The data is not strong, and therefore we don't use it. We still do not recommend that. Obviously, there is Amy Dizon's data in the haploidentical for aplastic, which is also the protocol that you are following with the 4-grade TBI. I think for haplo, obviously, that's the way there for even benign transplants, but I wouldn't recommend it in 2025 for sibling and unrelated donor transplants for benign disorders. I don't see a strong data already existing, so can't make that recommendation.
And the other question is MMF mofetil versus mycophenolate sodium. Which one do you prefer?
Institutional preference, whatever you like.
Right.
I don't think there is any difference that was seen, and if even if there is, it's probably just a small study which has shown here and there. But really, it's the institutional preference that we would go by, whatever you're comfortable using.
Dr. Sumit Mirg has a very important point to make. Phase 2 study from the Halton group, 75% very high rates of grade 3-4 mucositis, many of them needing TPN. So for PTCY with TBI based or melphalan based conditioning, how do you factor in for the mucosal toxicity? I mean, we see a lot of this when we use flu-mel background with PTCY, significantly higher mucositis. So how do you approach these patients?
Great question. Always, Dr. Mirg has always the best questions. So yeah, I know. Grade 3, grade 4 mucositis problematic. We don't use melphalan at all. We don't see these issues as commonly. Obviously, we do see it when we use etoposide TBI or fludarabine high dose TBI for our younger patients. Grade 3, grade 4, a lot of patients needing TPN transiently as well. So, yeah, it is a concern. But is it worsened with PTCY? You would still see those mucositis with the non PTCY approaches when you're using high dose TBIs. But without using the Flumel, I think with the fludarabine, busulfan, and 2-grade TBI protocol that we use for our RICs, we don't encounter grade 3-4 mucositis because most of our donor, also our recipients are much older than 60. So most of our transplants are reduced intensity. And if they are not reduced intensity transplants for the younger ones, or even if a reduced intensity, we are not using MEL. And as he rightly said, with the MEL based protocol, many studies have shown a little bit more increase in the mucositis issues. So I think fludarabine, busulfan, TBI, more of grade 1, grade 2 mucositis, lasts for around 4 to 5 days, 6 days, and settles down. Really rarely need TPN for those.
Do you use triosulfan for any subset of patients? And does it or
Yeah.
is it busulfan both elderly, young, all patients?
So we would like to use Trio for a lot more people. The problem with Canada is the approval, right? Like it's not approved for anything outside of AML MDS. So for MF transplants, we can't use it. We use it for CMML as well. So it's MDS MPN overlap, MDS, as well as now for AMLs, which is a recent approval. We are using Flu Trio 42 or Flu Trio 30 grams, and that is what the approval is. We're using it more often now than we did in the past. There's also some published literature from our group. Dr. Pasek had published a couple of years ago about our experience using triosulfan. And as you rightly said, better tolerated than busulfan, some anti-leukemic property as well. So we try to use it more often than not now. If we can get away with busulfan, that would be good. But for now, it's more of logistical limitations and barriers other than the medical aspects of it.
Is there a concern about increased risk of donor-derived leukemia or secondary malignancies because of exposure of stem cells to PTCY? Some few reports here and there, but is there a concern of donor-derived leukemia?
Well, like I said, I looked at this large data set, right, when we looked at the second primary malignancies. So we did see some patients who had hematological malignancies as their second primary malignancies and different from the malignancies that they were transplanted for. So I carefully excluded those patients who had MDS to begin with and then relapsed as AML. I excluded them as well. So anyone, when I said, and there were like 15 patients only who developed hematological malignancies, for them we had cytogenetic data at diagnosis as well as at the time of relapse. Hard to point, many patients were much earlier than 2015 when this data set was not very robust. And we were not even using PTCY back then. So I've really not encountered a defined donor derived leukemia, like meeting the criteria for donor derived leukemia with PTCY. And I don't know if that concern is justified. There is hypothesis behind it, but I don't think that's translating into a clinically meaningful outcome, like, or a clinically meaningful increase in those leukemias. I haven't seen that personally, but again, my experience is quite limited.
Do you start cyclosporin from day -2 or do you stick to the standard day +5?
The standard day +5. So MMF also on day +5 to 35, cyclosporin day +5 to 60 or 90, whatever it may be. But we're not starting anything before the PTCY. And I think there's also a question about the CRS strategy. So usually we do a wait and watch approach. If it's significant CRS or something, then we try to give very low doses of hydrocortisone, avoid any other steroid for that matter, just the standard which everyone around the world has been following. But really, we don't feel, and again, Professor Bachigalupo will not agree with this, right? So they do start on day -1, I believe, cyclosporin as well. They do things a little bit differently with good outcomes. So who knows what's the right or wrong approach? We're starting at day +5. And for the CRS, we manage it conservatively and a little bit of hydrocortisone if the patient's condition justifies it, but really no standard of care.
So in a haploidentical transplant with flu trio TBI protocol, and like you mentioned, the same, we also follow the same. We start cyclosporin from day +5 and MMF also from day +5 along with GCSF. We see patients, getting fever, high grade fever sometimes by day 10, day 11, around the peri-engraftment period. And sometimes when we have not really acted on that, a few of our patients have had a early rejection also, somewhere between day 10 to day 12 fevers, some associated with infection may or may not be. And for a few patients, we tried monitoring IL-6 ferritin levels, significantly high ferritin levels, sometimes IL-6 going into 500 to 1000 range. So my question is, one, do you encounter such a scenario, fever between day 10 to day 14? And do you really act on those IL-6 levels by giving tocilizumab or slightly higher dose steroids like methylprednisolone?
Okay. So yes, so we do encounter peri-engraftment kind of fevers. I believe that's what you're referring to. And again, IL-6 and ferritin, because it's inflammatory in origin, are expected to be elevated. No, we don't give tocilizumab. Like, I don't think in the last 3 years I've encountered any patient who's received tocilizumab for this. Also, steroids, we are very conservative when we use them. If the patient's condition is deteriorating to an extent that they need, supportive care in the intensive care unit or any reason elsewhere that they have a lot of fluid in the lungs or they're accumulating like third spacing, then we would consider steroids, 0.5 to 1 milligram per kilogram, just like an engraftment syndrome kind of thing. But no tocilizumab. Again, even if we want to, we won't get it approved. So that's another barrier. But more often than not, we just sit tight. Sometimes we have patients who need steroids. When we give the lowest dose justified, we start at nothing more than 0.5 milligram per kilogram of prednisone or equivalent, and then maybe increase to 1 milligram per kilogram if there's no improvement. We have a very low threshold for performing bronchoalveolar lavages before the patient's condition deteriorates to any extent. So we try and get all microbiological evidence before that, and we've been very lucky with that. It's possible just around the unit. So more often than not, we do identify a causative bug. So we treat both in conjunction, and then we would further be not in favor of giving tocilizumab. So that's also another reason that we try very actively to get something and chase it. So low dose steroids, very low threshold to get an infection, treat obviously empirically, followed by then targeted approach. So just the medical management to it, nothing that we do differently.
Dr. Raj has a question. ATG dose, any difference in sibling versus mud with PTCY?
Yes, highly different. So sibling donor, the dose is 0. Mud donor, mud is 2 milligram per kilogram.
Basically, you do not use for sibling.
We don't with PTCY. No, we did use it in just 34 patients, which we reported already in that blood advances paper. But then we saw that even in that small group, there was a lot of reactivation. So it was just decided to just change practice as a quality of care measure. And since we started using PTCY, CNI, MMF, we still get the same benefits in GRFS, but without the EBV, CMV, and those EBVs were actionable EBVs, Nikhil. Those were different from what I'm talking about.
Right.
So couple of changes, and this is how the unit learns and grows as well, right? Like you learn that this is probably not working. You do an introspection, and then just report that and change practice. So no sibling donors don't get ATG at our center, at least because we use PTCY. But if you're not using PTCY, if you're using CNI MTX, then I really don't know what the way forward is. And I would recommend using PTCY because now there is phase 3 data as well. So definitely that New England paper is practice changing. It has a lot of flaws. I'm not saying that it's a perfect paper. They didn't report the rates of bloodstream infections for one. So that's something that definitely has not been reported and should be reported. But beyond that, I mean, the results are out there, right? When we look at the hard metric of GRFS, which is the primary endpoint, it's 50%. That is what we are expecting across the board. And the goal is to get 50% in all donor types. Then we can truly say that the donor doesn't matter.
Absolutely.
And that's a composite endpoint. So we're then looking at GVHD as well as relapse, right? So when we say the GRFS is the same at 50%, we're assuming that GVHD is also not too high and relapse is also not too high.
Right. And again, something which we have been debating in our unit, ATG versus PTCY. Obviously, ATG, there is a non-selective depletion of T cells, and PTCY is selective for alloreactive T cells while sparing the Tregs. So do you think theoretically this would translate when you look at, I don't know, there's a head-to-head trial of ATG versus PTCY, but if you actually look at your own data, do you think the relapse rate should be theoretically lesser with PTCY because it's a selective T cell depletion?
Yes, again, if you look at a blood reviews series with Shannon McCurdy has written a very beautiful review. And I think they've made a very valid point that, okay, everybody has skepticism with PTCY increasing relapse. There's non-significant trends. We keep using these terms, but there is a biological rationale by which it reduces the risk of relapse or doesn't at least increase the risk of relapse. So that paper is something that I always swear by. And even in the real world setting, and even if you look at phase 3 data, forget the retrospective data from our center, they've none of the studies like BMT 1703, I don't think showed an increase in relapse. Even the CAR study, the New England 2025 paper, has not shown an increase in relapse. So I don't know why we believe that PTCY will. On the other hand, ATG, yes, there have been concerns, but it's very important to note that all the studies have shown a dose dependent relationship with infections and with the relapses. And we don't know what the dose is, but it's certainly longitudinally incremental, right? I can't say that I dichotomize at 5 and it will not happen or happen. But if I look at it as a continuous variable, the higher dose will be associated with higher complications, higher relapses, higher infections, and definitely lower GVHD. But then where is the delicate balance? That is the trade-off. With PTCY, we don't see that relapse risk even at the 50 dose. If we go down further, which is what I highly think we should do, we might even be able to not see that non-significant increase in the numbers that we are seeing. And with ATG, anything less than 4.5, anything less than 4, I think that's comfort zone. It really it's probably the balance between the efficacy and the toxicity. So I think what you guys are using at fMRI is probably less than that 4.5. So I think it should be good enough. But again, long-term data and every patient is different. Retrospective data, we sometimes don't have DRIs for these patients, right? So we don't know if it's the disease biology which is driving it, and just we are blaming the ATG for it. But definitely dose dependent relation with ATG.
So we use 2.5 for mud, 2.5 for mat sibling and 4.5 for mud. So that's been our standard dosing.
Yeah.
Dr. Narendra has a question. Can we give flu mel TBI PTCY for mat sibling? Is there any data on that?
So yeah, I mean, most of the patients who did receive PTCY on the BMT-CTN 1703, majority received Flumel, right? And there were around 30% patients who were sibling donors as well. So there, I'm sure there was an overlap. In the CAST trial, and I'm only referring to phase 3 data right now because that is the most, the best data basically. I don't think that the CAST trial, I don't remember at the top of my head what the conditioning was, but they did use some amount of Flumel based conditioning. So there is some data. You'll have to do a deep dive into both of those New England papers to see exactly. In the supplement, it's definitely listed out which conditioning regimen was used for which patient. And since the cast was only sibling donor transplant, I'm sure that there were some with Flumel. So you can find your data there.
What
Yeah,
do you
is the flu trio can be better? I'm just a question. Flu trio and TBI.
Uh, yeah, I mean, why not? There's no I don't think that there is any data which will look at every single conditioning regimen in isolation. But Flutrio TBI is what we are also using when available, but we are not using it for sibling donors yet. And even if we have, it will be very few patients. So personally, I don't have that experience, but I don't see how a different conditioning regimen would make that much of a difference to the GVHD prophylaxis because it's always been a dealer's choice when it comes to conditioning, and we just club it as MAC or RIC based on the definition. So I think be it flu trio, be it flumel, you might see a few differences in mucositis, as Dr. Marg also pointed out. But I don't think that your GVHD outcomes would be significantly different based on that.
You told about FDS MPN. You guys are using triosulfan. What is the
Yeah.
rationale? And shall I? I have a 62-year-old man with the MDS MPN and in remission, with AML in remission. So I'm just planning to use it. So is it? I'm worried about toxicity and infections.
My main concern with MDS MPN and that too in the blast phase, although in remission, would be the relapse, nothing else.
Yeah.
Because we also published recently our MDS MPN data, and the biggest question that we had was concern that we had rather was relapse. So I think beyond this, I would try and optimize giving them as myeloablative a conditioning as possible. I don't know if you told me the age or I missed it, but if they are young and fit for myeloablation, certainly try and myeloablate it. That's probably the only thing that will help, and early tapering of immunosuppression.
Thank you.
Thank you, Dr. Narinder. Dr. Sumit has a question, and again, a very interesting one. Post inotuzumab, when we use PTCY, what would be your preferred conditioning be as per donor type? And does in this setting, is there an increased risk of VOD with PTCY?
Yeah, I mean, yes, there are soft signs towards increased VOD. Again, it could just be fluid toxicity masquerading as VOD. So we really don't know if it's truly meeting the criteria of severe VOD or it's just toxicity and other complications masquerading with as VOD. But post inotuzumab, things definitely get a lot challenging. I would avoid using high dose TBI, dual alkylators, standard approaches as any other person would use. Preferred conditioning, I don't have a preferred conditioning based on that. A spacing strategy, maybe 3 months of gap if that's possible. If there is risk of relapse, obviously we are limited by that as well. So a lot of nuance to this discussion. But preferred conditioning, I would try and avoid dual alkylator conditioning. Maybe flu trio would be a better option. Reduce toxicity if that's something that we can get away with. But nothing really more. Dr. Sumit, if you're on and would like to add anything.
Dr. Sumit, are you there?
Hi, am I audible?
Yeah, you're audible.
Yes,
Please go
boss.
ahead.
I couldn't find an answer to this. That is why I tipped the question to you, and I'm still searching for it.
Sorry.
I couldn't find an answer for this. We wanted to use TBI-based conditioning. Ultimately, we use Flumel with PTCY for our patient. He's doing well, but I don't know if there's any standard of care or any actual preferred regimen in such a condition.
I don't think I'm aware of any of that, but just the standard recommendations. I think the Flumel PTCY, hopefully the patient does well. That's all. Don't know. I
Yes.
don't know the answer to that, honestly.
But Dr. Sumit, if a patient, relapsed ALL patient has received mini hyper CVD with INO, and you're waited for 4 to 6 weeks, you've given hyper CVD 1A with INO and probably the 1B at a reduced dose without INO. Couldn't you still go ahead with a TBI based conditioning? I mean, what do you do in your practice? Because we go ahead with a standard flu TBI PTCY for this patient. We wait for 4 to 6 weeks. We do not really avoid TBI in this setting.
So our patient Nikhil was a primary refractory BLL who achieved a remission with inotuzumab only, and we couldn't unfortunately wait for 4 weeks, and the dilemma was that while we would always prefer to give a TBI based myeloablative conditioning in such a setting, but because that was not possible because of his disease biology, we went at Flumel 140 and PTCY. Until day plus 45, he has done well, no VOD. So at that time, when we were discussing about the conditioning, we were debating as to what to do.
Right. I mean, in that setting, yes. If you cannot give a gap, then it becomes a tricky situation. Yes.
Yes.
I think good
And
call for avoiding the TBI for sure.
right. Dr. Nitin Gupta has a question. Do you really need MMF in match-related or mud transplant? When PTCY with cyclosporin isn't it good enough? Is there an additional benefit to adding MMF?
I think I covered a bit of that in the
Yes.
talk.
You did.
I mean, look, definitely it's what Dr. Rotesh Mehta's data shows is quite perplexing. It's funny that they show that there is an increase in the GVHD grades 2 to 4, and now we know that the cast trial showed that PTCY cyclosporin alone is enough for match related donors. Certainly, why not? I mean, you can back your claims based on that trial and justify using it in a patient, I believe. What we are doing currently is not that. We are using PTCY MMF CSA not because of lack of data, but because of probably we still are doubting the quality of data. They've also not reported in the trial how long they continued cyclosporin. But when I heard them at EHA, I think they said that the median duration was 3 to 4 months. So slightly longer, maybe a slower taper. So we don't know. That's not been reported in the trial, even in the supplement. So they've just mentioned that no one came off before day 90, which is what we do expect with that. So without the CSA, without the MMF, when to taper CSA, we don't know. So it's because of those reasons that we have not changed practice, and we're still in the middle of that. So we'll go to a middle ground, I guess. We'll drop the dose a little bit and then completely take it off if we don't see any safety signals. So maybe you can justify not using it. That's fine.
Right. So thank you, Nihal. I am Dr. Nitin here. So I think I am not using it, and most of the time we need to in house stop it MMF because of the prolonged cytopenias in our patients. So even in the haplos also, probably my experience is that MMF is usually not given as per the Hopkins protocol. So another thing I just wanted to know that because relapse remains a problem in leukemias. Um, and we know that some kind of little bit of GBHD is good for relapse prevention. So, what are your strategies to kind of augment that effect of GBL by tweaking the dose of PTSI or reducing the maybe giving one dose or reducing the dose? Will you comment upon that?
Yeah, certainly. I think PTCY and relapse is something that we truly believe doesn't really drive relapse. So it's something else. So it's the depth of remission before transplant. It's the duration of cyclosporin that we would try to tweak rather than meld with the PTCY, because we know that giving PTCY on just one day initially when it was used did not lead to good results. So we don't use only on one day. We do use it on both the days. We've dropped the dose not for the relapse risk, but for the toxicity mitigation rather. For relapse prevention, what I would highly recommend is definitely depth of response before transplant. Early taper of immunosuppression is something that really goes a long way. Making sure we attain full donor chimerism at both days 30 and 60. And I mean, like, we do the fractionated chimerism and aim for full donor T cell chimerism. These are the things definitely. And if you have a targetable mutation, definitely try and use an agent for that. Not a big fan of prophylactic DLIs, or like, in that setting I wouldn't be able to comment. I don't like prophylactic as a word for DLI. There's a lot of risk benefit ratio that has to be calculated, and very very nuanced discussion. But depth of remission is something that we can optimize. Early tapering of immunosuppression is something that we can optimize, and maintenance strategies, if available, are something that will reduce the risk. But beyond that, PTCY dose for relapse mitigation, I don't think there is any backing for that.
Thank you.
Thank you, Dr. Nitin. Moving on, Dr. Ash, last couple of questions. Dr. Ashish Verma has a question. One, I think the first part we already discussed, the ATG dose, is there any difference in sibling and mud or mud versus haplo? Do you use both PTCY and ATG in haplo transplants? I think you did show data for mud where you combine PTCY with low dose ATG, but do you do the same in haplo, number one? And is there any difference between proximal and distal end of conditioning? So early ATG versus closer to stem cell infusion, is there a difference?
Great questions, actually. So we did use ATG with PTCY for haplo. Initially, the dose was 4.5 milligram per kilogram when we were using it. So it was days minus 3 to 1, so proximal uh, to the time of stem cell infusion, rather. We've never used it distal. Minus 3, minus 2, minus 1. The days were 0.5, 2, and 2 on each day. So it total comes to 4.5. That is how our standard haplo backbone was. So PTCY on 3 plus 4, 3 and 4, ATG on minus 3 to 1, and CSA starting on day plus 5. This was our haplo protocol. Recently, we noticed that might be a bit of an overkill because of the immune reconstitution that I was talking about, and that I haven't presented because it still, works under the covers, and there is a lot of people involved with the lab as well. So it's still being worked upon. But we did note that there was a significant delay in immune reconstitution, a signal towards increased non-relapse mortality, especially in patients more than 60 years of age, which is most of our population, right? So we dropped the ATG from the PTCY protocol for haplos. We just use PTCY MMF CSA for all donor types. Only in MUDs we use low dose ATG. That's because we think that that is the most delicate balance that we had found, with very promising results across all types, and that is the data that I presented as well. For all others, we are not using ATG anymore. And for haplos, we were using 4.5. For siblings, we don't use. And for MUDs, we use 2 milligram per kilogram. And all of this is very close to the time of stem cell infusion. So it is minus 3, minus 2, or minus 3, minus 2, minus 1, depending on what the dose of ATG is. We try not to exceed more than 2 mg per kg per day.
I think that provides a lot of clarity. And among all the data sets you showed, personally, I think the one with low dose ATG with PTCY in mud was very, very encouraging to see. Chronic GVHD rates. Typically in mud transplants, we see quite a significant chronic GVHD, but less than 20%, I think very, very impressive. Again, moving on to one of the last questions. Is Dr. Anusha has a question. Is cardiac dysfunction a real concern in PTCY use, and do you monitor echo NT-proBNP while administering PTCY? And I'll probably give a little bit of background from our group. So we do quite a few transplants for autoimmune diseases, multiple sclerosis, systemic sclerosis, especially when it comes to the systemic sclerosis transplants. And the standard protocol we use is rituximab, cyclophosphamide, and ATG. So the cyclophosphamide, initially we used to dose at 200 mg per kg, and later on cut down to 150 mg per kg because of risk of cardiac toxicity. So in such patients, very often we encounter, after a single day of cyclophosphamide, patients have cardiac decompensation, and very often we are not able to give a second or third. Rarely in haploidentical transplant, especially in elderly patients or in even younger patients who are obese, we have encountered this problem where we have given a day 3 cyclophosphamide. There is an acute cardiac decompensation, and then we don't know whether we need to continue or probably give a second day of bendamustine. So what is your approach to cardiac dysfunction with PTCY? And I think you mentioned in your talk regarding using NT-proBNP as a marker to facilitate diuresis. So can you elaborate on this a bit?
Yes, certainly. Very, very valid question and very, very important points, like you said. So I honestly have no experience with autoimmune transplants. We are a malignant center, malignant transplant center, so we don't usually do autoimmune transplants. Other centers in Canada, like Ottawa, have a lot more experience than Princess Margaret Hospital. That's just the way the structure is. Cardiac dysfunction, irrespective of the underlying disease, I will tell you that, yeah, we do see some issues. uh, pre-transplant optimization really helps. If there is someone with a cardiac dysfunction, we would certainly prioritize. Even before the pilot study was commenced, we used to give them a slightly lower dose, or maybe avoid PTCY in those settings. So yes, the concerns were there. But for the ones who we've committed to using PTCY, uh, I've rarely encountered anyone develop sudden cardiac decompensation that prevents the day 4 dose from being given. There is some fluid toxicity. There might be a little fluid in the lungs, some third spacing, but that can be diuresed. That can be mitigated by reducing a little bit of hydration for a while. The rate, I mean, not stopping it completely. We reduce the rate for a while. That can be done. But I have never had to not give day 4 cyclophosphamide because of an issue that arose on day 3. If that issue is arising on day 3, it's probably there even at day -3, and we have probably not optimized that before that. But just one dose, I don't believe that would lead to prevention of day 4 dose from being given. That's just my experience over these past couple of years. But if anyone has a different opinion, I think bendamustine, there is data from, I think, 2 centers. Professor Nair has reported recently, which I was showing, and also there is another data from West Bengal that has come in. Arijit is also on that paper. It was a study at Tandem that they presented as a poster, I believe. Also using day 4 PTC instead of PTCY, using Benda. So I mean, there are options, and if you do encounter this rare patient, certainly Benda is just 90 mg per meter square, 1 hour infusion, no hydration, like little less, much easier to administer. So I'm sure that there will be more data in the coming years if we encounter these patients more often. I haven't in my practice, and I'm thankful for that.
So again, it has been very rare in haplotransplants. We have encountered this, but yes, in an autoimmune setting, this is something which we encounter very often. And there are standard
So
practices.
I think that's why I mentioned if it's actually a real concern or not, because I think we become a little too cautious with our experience in the autoimmune setting. And we actually, as a routine, monitor echo every day. And sometimes I wonder what do we do with that information, except that it adds a bit of anxiety to the situation. So, yeah.
No, very, very valid point. I think we all suffer from this, right? Like we sometimes over investigate to treat our own selves. But you guys are doing autoimmune transplants. So as I said, these underlying diseases are more complex. Patients are coming in with some pre-existing cardiac dysfunction, pulmonary hypertension. I'm sure that can be a very challenging complication to manage. And I don't know if I have encountered those patients, most likely not. Subtle pulmonary hypertension, certainly, but not autoimmune disease specific transplants we don't do. So as I said, the information might be limited by that. But again, we do have options, right? If you feel that the fluid toxicity is prohibitive, I think bendamustine is a potential. At least there is potential to use that as a last resort, and pretty easily available, right?
True. So Dr. Anusha in our group has a lot of experience with autoimmune transplants, especially in this setting. So I mean, she can probably elaborate a bit on that, but
Yeah, that would be great actually. Like how would you, like what's your real world navigation strategy?
Yeah, so autoimmune, yeah, difficult set of patients to begin with. Many of the systemic sclerosis patients, at least, are already on oxygen support at baseline when we take them up. So we take it on a day-to-day basis. We do not try to overreach the dose of cyclophosphamide. We always try to ensure that what is tolerable is only given. We know that the immunosuppression is what we're going for. But then you're right. The patients who have a PASP of more than 40, when we take them up, we do take them up. We don't use it as an exclusion criteria. We do take them up. We do try to administer the cyclophosphamide with the adequate hydration. But then more than 50% of the times, we do end up modifying the dose of cyclophosphamide for these patients. And we see that the NT-proBNP obviously precedes the echo changes. And actually, the boat train has already left the station if you're finding it with a reduced ejection fraction. Do you routinely monitor NT-proBNP at least while you give PTCY?
Yes, so we monitor it every day, starting day +3, and then up to day +6. So 3, 4, 5,
Okay.
6. Those are the days, and then we sometimes act accordingly and modify a diuresis strategy, give an additional dose of Lasix accordingly. If it's really sky high, then we get echoes, because it's very difficult for us to get echoes. I'll be very honest. So it's
Okay.
I would
Okay.
like more echoes than I get, and I would like, yeah, no, I'm pretty happy with the number of bronchoscopies we get with, so it's okay.
Right. So actually, we are getting
Challenging.
echoes and NT-proBNPs. Like I said, we are not very sure because obviously the last thing we want to do is cut down on a day of PTCY because the roadmap after that becomes very murky.
Definitely.
So yeah, thank you.
I think really challenging situation and different underlying diseases, so many different problems. Again, just just a disclaimer that most of the data I presented is for malignant transplants, so might not apply outside of malignant transplants. A little bit to maybe some aplastic anemias, which also Nikhil shared the protocols, but mostly to malignant transplants. Most definitely not applicable to autoimmune transplants. Just a broad disclaimer.
Thank you, Dr. Nihar. I think we have taken up way too much time. But if I could ask one last question, I mean, just that we are curious, do you routinely do immune reconstitution panels in your setting? We have developed a panel, Dr. Asta spearheading the effort from the hematopathology side, so that we can really monitor and see how long should we give valacyclovir, Septran, and we have patients coming in as late as 1.5, 2 years post-transplant with serious infections, which has left us wondering how long does immune reconstitution actually take? So is that a standard practice that you monitor them for B and T lymphocyte subsets, and do you change your prophylaxis, your monitoring strategies based on that?
That's such a nice question, Nikhil. I mean, so many things to be added on this. So, yes and no, and very physician specific ways of doing things. I'll touch a little bit on everything. Again, because there's no standard operating practice, we don't have an SOP for this, but we are in the process of creating some. I think Dr. Viswabandya is leading that effort as being the head of quality for our program. So there is some stuff that he's looking into. With regards administering the first post-transplant vaccine, we try to get a flow for lymphocyte enumeration before the first of the Prevnars that we give on day 120. That's our standard protocol. And we have seen, as you are also saying, delayed infectious, right? So we published that in European Journal a couple of years ago, actually in 2023, about late PJP reactivations, all bronchoscopy proven and PCRs for them available. I think we had 14 patients, so it was more of a case series with obviously potential of selection bias, but we did see that, and everybody didn't have CD4s less than 200. So is it just the number? Is it the functioning? And these were all patients off immunosuppression, by the way, and no GVHD. So I'll make sure that was covered. These are apparently healthy patients in your and my eye, right? So these are patients off immunosuppression, meeting the GRFS endpoint probably, but they still came with 2 years like later after transplant, where we don't expect them to have infections, and they came with PJPs, which required treatment. Thankfully, most of them were treated, caught in time. I think one mortality or two mortalities, if I remember correctly, out of 12. Majority did well and are still following up. But do we know? Because we stopped the Septra once the CD4 was more than 200. Also extrapolating again from the HIV literature.
True.
A
We do
little
this.
bit like we really don't know what's right and what is really immune reconstitution, what is really truly defined as being robust counts, right? We just take these numbers which are arbitrarily defined, or for other diseases there is a data cutoff, but not for transplant. At least I'm not aware. So we do monitor it, and the reason that we've not created an SOP is because of so many the data is all over the place. That's why we've not been able to come up with a data driven SOP. We want to, and we try to do it. We wouldn't give any vaccine if someone has literally like zero B lymphocytes. What is an actionable level? Where would you give it? We don't know. Whatever you're comfortable with. So these are these gray areas in transplants. That's what I feel. But if you guys can generate some data, and like that will be really helpful, because I'm really not sure. Even if the numbers are there, how do we prove that they are functionally robust?
True. I mean, that's a very valid point. It's very, very difficult to assess the quality of cells. All we can trace is numbers. And again, we don't have very robust data from the transplant setting. But even for your haplo transplants, did you start vaccination as early as 4 months? Or do you wait? Because it's been our standard practice to at least wait for 9 to 12 months in a haplo identical setting. Every other setting, 4 months has been our starting point. But for haplo also, do you start early?
Yes, we are. As long as they are off immunosuppression and have, reasonable physical function, reasonable counts, no really ongoing infectious issues, we don't, the donor type doesn't dictate our first vaccination. So we would aim to give the first of 3 Prevnar 20s at day 120. If not, then latest by 150. If there is severe B cell aplasia, there is some ongoing issue, then obviously we delay it on a case by case basis. But our standard practice is to try and give it at 120.
Okay. So I think all of us can go on and on asking you more and more questions because it's such an interesting topic and there is a lot to be covered. But
Yeah, it
due
was
to lack
quite a
of
lot to be discussed as well, and this was really a very interactive discussion. More than the talk, I think I loved the sessions. I mean, the question answer. There was so much to learn from everyone. I'm so glad that even seniors like Mukul Agarwal sir and everyone else was here. Colonel Uday was here, so that's really good. I'm very happy with you guys organizing this, and again, thanks again for the invite.
Thank you so much, Dr. Nihar. Over the last 2 hours, I think you have given an overview and we have discussed everything at length. I thank everyone who actively participated in the discussion and contributed to this webinar. Again, wonderful discussing with you. And I think going back, we'll be a little wiser and a lot of unanswered questions regarding what is the best GVHD prophylaxis in an Indian setting, considering our high risk of gram-negative infections and more importantly, the cost constraints. And we would
Definitely.
really like to collaborate with you on these front, especially on the research front. Many of us from India would be very, very happy to collaborate with you. And we would like to invite you over for more such transplant-related webinars in the future. But once again, thank you again for sparing a good 2 hours of your time and joining us this Friday evening. Thank you.
No, thank you so much. I really appreciate it. You guys have a great evening, and thank you once again for the invite and for joining everyone. Great discussion and lots of learning. Very happy to collaborate in whatever way that's possible for us, and very happy to help in, with data preparation, manuscripts, biostatistical support, whatever way one can help. So good luck, guys.
Thank you so much.
Thank you, guys. Bye. Take care. Thank you. And we should catch up, Nikhil. Thanks.
Absolutely. Please do let us know if you come down to Delhi.
Absolutely. Yeah.
We'll be happy to arrange a live.
Let's catch up. Yes. We'll talk offline. Yeah.
Thank you.
Bye. Bye, everyone. Thank you.
Recording stopped.